Welcome to Pediatric Case Review. Today we present a comprehensive lecture on bronchiolitis. We will cover clinical presentation, examination findings, pathophysiology, diagnostic approach, treatment strategies, and potential complications. This case-based review is designed to enhance your clinical understanding through practical scenarios and evidence-based explanations. Case Scenario 1. A 5-month-old infant presents with 2 days of runny nose, cough, and low-grade fever. Now the infant has rapid breathing, is feeding less than usual, and has diffuse wheezing on examination. What is the most likely diagnosis? Option A, bronchiolitis. Option B, bacterial pneumonia. Option C, croup. Option D, foreign body aspiration. The correct answer is A, bronchiolitis. This is a viral lower respiratory illness affecting infants under 2 years of age, typically presenting after an upper respiratory prodrome. Key features include diffuse wheezing or crackles, mild fever, and feeding difficulties. Bacterial pneumonia usually has focal signs and higher fever. Croup causes inspiratory stridor. Foreign body aspiration often has sudden onset with unilateral findings. Case Scenario 2. A 2-month-old infant presents with nasal flaring, intercostal retractions, and prolonged expiration. Which chest finding is most typical of bronchiolitis? Option A, localized egophony. Option B, diffuse wheeze and crackles. Option C, inspiratory stridor. Option D, unilateral absent breath sounds. The correct answer is B, diffuse wheeze and crackles. Bronchiolitis causes widespread small airway inflammation resulting in bilateral wheezing and coarse crackles throughout both lung fields. Localized egophony suggests consolidation from pneumonia. Stridor indicates upper airway obstruction. Unilateral absent breath sounds suggest pneumothorax or focal obstruction. Question 3. Why does hypoxemia occur in bronchiolitis? Option A, small airway edema and mucus leading to ventilation perfusion mismatch and air trapping. Option B, alveolar wall destruction. Option C, chronic smooth muscle hypertrophy. Option D, surfactant deficiency. The correct answer is A, small airway edema and mucus causing ventilation perfusion mismatch. Viral injury causes epithelial necrosis, edema, and mucus plugging in terminal bronchioles. This leads to air trapping, atelectasis, and impaired oxygen exchange. The other options describe emphysema, chronic asthma remodeling, and neonatal respiratory distress syndrome, which are different pathophysiologic processes. Case Scenario 4. During a daycare outbreak in winter, a 7-week-old infant develops cough and wheezing. Which statement is most accurate? Option A, peak age 2 to 6 months, winter season, respiratory syncytial virus predominant. Option B, adolescence, summer, rhinovirus predominant. Option C, neonates, year-round, bacterial predominant. Option D, school-age children, spring, influenza predominant. The correct answer is A, bronchiolitis peaks between 2 and 6 months of age, primarily occurring in winter months. Respiratory syncytial virus is the leading causative agent, accounting for the majority of cases. Other viruses include rhinovirus, human metapneumovirus, parainfluenza, and influenza viruses. Case Scenario 5. A 3-month-old infant was born at 34 weeks gestation, has hemodynamically significant congenital heart disease, and lives in a home with smoke exposure. Which factor increases risk of severe bronchiolitis? Option A, exclusive breastfeeding. Option B, age greater than 12 months. Option C, prematurity or congenital heart disease. Option D, up-to-date immunizations. The correct answer is C, prematurity or congenital heart disease. High-risk factors include prematurity, age less than 12 weeks, chronic lung disease, significant congenital heart disease, neuromuscular disease, immunodeficiency, smoke exposure, and crowded housing conditions. Breastfeeding is actually protective, and vaccines do not worsen disease outcomes. Case Scenario 6. A 9-month-old infant presents with classic bronchiolitis symptoms, mild distress, and stable vital signs. What is the best diagnostic approach? Option A, routine chest X-ray and blood tests. Option B, viral polymerase chain reaction and complete blood count for all patients. Option C, clinical diagnosis plus pulse oximetry. Option D, sputum culture. The correct answer is C, clinical diagnosis plus pulse oximetry. Bronchiolitis is primarily a clinical diagnosis based on history and physical examination. Pulse oximetry helps assess oxygen saturation. Imaging and laboratory tests are not routinely indicated. Consider viral testing only for cohorting purposes during admission or in atypical cases requiring broader differential diagnosis. This diagnostic algorithm summarizes our approach. For the vast majority of infants with typical symptoms and stable vitals, the path is green, clinical diagnosis only, with no labs or imaging needed. If there is severe distress or atypical features, we move to the yellow path and consider a chest X-ray to rule out pneumonia. Viral testing, the blue path, is primarily for infection control purposes during admission, not for diagnosis itself. Case Scenario 7. An infant with worsening work of breathing undergoes chest X-ray evaluation. What is the most typical finding? Option A, lobar consolidation. Option B, hyperinflation with peribronchial cuffing with or without atelectasis. Option C, pleural effusion. Option D, pneumothorax. The correct answer is B, hyperinflation with peribronchial cuffing with or without atelectasis. These findings reflect air trapping and small airway inflammation characteristic of bronchiolitis. Lobar consolidation suggests bacterial pneumonia. Pleural effusion and pneumothorax are uncommon complications in uncomplicated bronchiolitis cases. Case Scenario 8. A 6-month-old infant has respiratory rate of 64 breaths per minute, oxygen saturation 89% on room air, and poor feeding. What is the next best step? Option A, oxygen to maintain saturation greater than or equal to 90%, nasal suction, and hydration. Option B, start broad-spectrum antibiotics. Option C, routine bronchodilators and systemic steroids. Option D, discharge with cough suppressant. The correct answer is A, oxygen to maintain saturation greater than or equal to 90%, nasal suction, and hydration. Supportive care is the cornerstone of bronchiolitis management. Provide supplemental oxygen, perform gentle nasal suctioning, and ensure adequate hydration. Consider high-flow nasal cannula for moderate to severe distress. Antibiotics and systemic steroids are not routinely indicated. Bronchodilator trial may be considered case by case. Case Scenario 9. A 10-month-old infant with bronchiolitis has copious secretions and poor oral intake. What is the best hydration strategy? Option A, fluid restriction. Option B, oral fluids as tolerated. Consider nasogastric feeds if needed. Option C, dextromethorphan. Option D, loop diuretic. The correct answer is B, oral fluids as tolerated with consideration of nasogastric feeds. Maintain adequate hydration with small, frequent oral feedings when possible. Use nasogastric tube or intravenous fluids if oral intake is inadequate. Avoid cough suppressants in young infants. Diuretics and fluid restriction are inappropriate unless specific comorbidities exist. Case Scenario 10. A 6-week-old infant had an apnea episode at home. Current respiratory rate is 70 breaths per minute, oxygen saturation 88%, and feeding is poor. What is the best disposition? Option A, routine outpatient care. Option B, admit to general ward. Option C, admit to intensive care unit. Option D, discharge with home oxygen. The correct answer is C, admit to intensive care unit. Indications for hospitalization include apnea episodes, persistent hypoxemia, severe respiratory distress, dehydration, or high-risk infant characteristics such as age less than 12 weeks, prematurity, or cardiopulmonary disease. Intensive care is appropriate for apnea, significant hypoxemia, or impending respiratory failure. Case Scenario 11. A toddler with prior respiratory syncytial virus bronchiolitis now experiences recurrent wheezing episodes. What is a known long-term association? Option A, reduced asthma risk. Option B, increased recurrent wheeze and asthma in childhood. Option C, chronic bronchiectasis is common. Option D, permanent pulmonary fibrosis is typical. The correct answer is B, increased recurrent wheeze and asthma. Bronchiolitis, particularly caused by respiratory syncytial virus, can be followed by recurrent wheezing episodes and higher risk of childhood asthma. Most children recover fully without long-term complications. Bronchiectasis and permanent fibrosis are uncommon without other underlying conditions. Case Scenario 12. A 9-month-old infant is on day 5 of illness and improving but still has cough. What is the best discharge advice? Option A. Full recovery in 1 to 2 days. Option B. Cough may last 2 to 3 weeks. Return if feeding worsens, fewer wet diapers, apnea occurs, or increased work of breathing develops. Option C. Daily antibiotics for 7 days. Option D. Avoid vaccines for 6 months. The correct answer is B. Bronchiolitis is self-limited with peak symptoms at days 3 to 5, followed by gradual improvement. Cough may persist for 2 to 3 weeks. Provide clear return precautions including worsening feeding, decreased urine output, apnea episodes, or increased respiratory distress. Ensure caregivers can manage nasal suction and maintain adequate hydration at home. Join our Pediatric Case review community on Patreon for exclusive benefits. Access all our videos organized by system in one convenient location. Download all presentation slides as images to read and practice questions at your own pace. For complete details and subscription information, simply type the word "join" in the comments below, and we will message you directly with instructions. Thank you for watching this comprehensive lecture on bronchiolitis. Remember the key principles: recognize typical presentations, provide supportive care, and escalate appropriately when needed. Please follow Pediatric Case Review for more informative presentations covering essential pediatric topics. If you have any questions or topics you would like us to cover, please leave a comment below. We appreciate your engagement and support.